Hi everyone, my name's Sarah, this is Tej, and we're both F1s in these teaching hospitals.
We're also part of the committee of Countdown. I'm one of the OSCE lead coordinators, and Sarah is in charge of research. So does everybody know about Countdown? You should have all received emails about it. So the emails that you had, they're the last now. So if you want to hear from us or you want to know what's going on, you need to go onto our website. We also have blogs, and we're going to start threads as well. So if you have any questions after the lectures or anything like that, of course you could ask us, but then if there's anything at home, you can go onto the threads. Also, like us on Facebook, please. And yeah, if you have any questions, let us know. And then if there's anything else I remember about Countdown, I'll let you know.
What do you think of this lecture theatre in comparison to the other one? Which do you prefer?
This one.
Okay, we'll keep it as this one then.
So please fill out the feedback forms. I know everyone hates doing them, but we are listening to you and we are trying to make more and more changes. So yeah, please fill out the feedback forms. If you don't have a handout right now, don't worry, because the lecture's been recorded and the handouts will be on the website and the video should be uploaded on Monday.
So you won't miss anything if you don't come to the lectures. That doesn't mean you shouldn't come, obviously. So we both used to work in cardiology in our last jobs, so that's why we're doing this lecture. So we're going to tell you a bit about doing a history and examination for your finals OSCE, rather than the stuff that you've been practicing. I think the last time you did cardiology would have been for your third year OSCE. So our aims and objectives, to build on the skills that you already have, as I've already said, so tailoring the skills that you have now towards your final year OSCE. And we want you to be able to adapt to the situation you're giving in your OSCE. In the third year, I think, from remembering how we did it, we had sort of a list memorised for your OSCE of the questions you would ask and the stuff you would do in your exam, and it didn't really waver from that list because your patients were all normal. But I'm sure, as you know, your fifth year OSCE, you're going to have some pathology in your exam, so you're going to have to adapt to the situation, adapt to what the patient's telling you, and adapt to the questions that the examiner's asking you. Don't worry if you don't stick to your original order, just go with the flow. And we want you to be confident in your diagnoses, because in some of your fifth year stations you'll be asked for a diagnosis at the end. And if you say to your examiner, which I definitely said on a few occasions, "Is it AF?" they don't look at you very nicely. They just want you to say it with confidence, and I'm sure they'll think you're great. We want you to feel prepared for the exam. There's no better feeling than going into an exam knowing all the possible things that could come up. So that's what we want for you, and obviously we want you to pass your OSCE. So content is what we're going to go through. A focused history. It's going to entail all the same sections that it would have done in your third year kind of history, but just focused down to cardiology. We're going to take you through doing an examination for your finals. So what kind of things to say when you're going through it and what not to say. And we're going to take you through some of the key things that you'll probably find in your OSCE. These are the 4 things that would probably come up. So it's going to be a stable patient in your OSCE. You're not going to come across someone with endocarditis or having an MI, because they're not going to have unstable patients in front of you. So those 4 things: aortic stenosis, mitral regurgitation, previous cardiac surgery, and atrial fibrillation are the common things that might come up. That's not everything possible that could come up, but it's just what might do. We'll also take you through a practical run through at the end. Hopefully we'll get a couple of volunteers from the audience just to run through the typical examination for your OSCE. We can point out what you might be doing wrong or what you could do better and what can speed you up a little bit so you can fit that examination into your 8-minute stations. So, starting off with your history. I'm sure you all know the basics set out to a history. What's the first thing you do when you walk into your exam station? Exactly. Wash your hands. What else? Yeah, and yeah. So you need to wash your hands, introduce yourself, and check who the patient is. Don't focus too much on hand gel, because if it's a history station, there might not be any hand gel. Don't waste your time looking around for it. If it's there, use it. If it's not, carry on.
Just say, "I'd wash my hands," and then carry on. So try and look for it.
So when you go into your station, you want to ask the set out questions that you know. So presented complaint, history of presented complaint and any associated symptoms of that presented complaint, past medical history, drugs and allergies, family history, social history and systems review. I'm sure you've all got that drilled into you by now. So we'll start with the presented complaint. what kind of typical cardiac presenting complaints are you going to expect? Yeah, what else? Yeah, anything else? Yeah, oh, you've got the handouts, haven't you? What else?
Without looking at the handouts.
Yeah, okay. Are you all confident with the differences between syncope and pre-syncope? Do you know what they mean?
Anybody?
So what's pre-syncope? How might someone describe pre-syncope when they're presenting to you? Yeah, so lightheaded and dizzy, and we'll come on to the difference between those later. And what about syncope? What means that someone's had syncope? Loss of consciousness, exactly. And if you get an old lady or man coming to you saying funny do, they usually mean pre-syncope or syncope. Okay, so when someone presents to you with one of these symptoms, just like to remind you, even if you think it's cardiac, probably go with that, but remember, it's not going to tell you what kind of a history you're taking on the station. They give you that little blurb, but it's not going to say cardiology at the top of it. So even if someone does present with chest pain, have cardiology in mind, but you want to be thinking about other things that could be causing that symptom that they're presenting with, and we'll come on to that a bit later. If they do present with chest pain, what are you going to ask them about it? Yeah, so go through Socrates. So what's S? Yeah, so where's it most likely to be if it's cardiac? And what would they describe it as? Yeah. What's O? Yeah. So what might they say about the onset? So when is it going to happen? Sorry, what was that? Yeah, on exercise usually. And what about the character? Yeah, exactly. Where does it go? Yeah, it can go up into their jaw, it can go down either of their arms. What about the alleviating factors? Yeah, rest. Timing. So how long does it last for usually?
So timing's really important if somebody comes with chest pain, because you want to know how long they've had it for to distinguish whether it's unstable or stable angina as well.
Yeah, so if it's angina, it might not last for that long. If they've had the chest pain for an hour and it's not going away, it's more likely that it's going to be an MI. Exacerbating factors. So what might make the chest pain worse? Yeah, position. So say if their chest pain is worse on leaning forwards, that might steer you more towards pericarditis. Unlikely that you'll get that in your exam though. Or like we already said, exercise might make it worse. Or say if they're eating food and they've got chest pain that's getting worse, you might be thinking more towards what? Reflux, did I hear someone say? Maybe. Okay, and severity, it's a bit of an iffy one. It depends on the person, but ask them how severe it is with a pain scale of 1 to 10. So that's chest pain. What if someone presents with shortness of breath? What are you going to ask them about? Yeah, how long they have it for? What else? Sorry?
Onset.
Yeah, onset. So what are the two kinds of shortness of breath you usually see documented? So it's usually, yeah, those two. You also get shortness of breath at rest or shortness of breath on exertion. But yeah, you want to ask about orthopnea, so do they get short of breath when they're lying flat? And PND, does everyone know what that is? So paroxysmal nocturnal dyspnea, when someone wakes up at night suddenly short of breath and they have to get up to catch their breath again. Okay, so some of the other things you want to ask about. Palpitations. What are you going to want to ask someone about their palpitations? So you want to ask them when they come on, what makes them come on, how long they last for, and what you can also do is ask them to tap out a rhythm for you, because it might give you a better idea of what arrhythmia they could be having. And don't forget to ask about caffeine, because that can be something that sets off people's palpitations. Also, lightheadedness. So what I was talking about before, if you ask someone if they're lightheaded, it's better than asking someone if they're dizzy, because what defines the difference between dizziness and lightheadedness? What kind of description are you looking for? So lightheadedness is what it is, lightheadedness. Dizziness is usually if someone sees the room spinning, and it might be associated with something like labyrinthitis rather than a cardiac cause of lightheadedness. So you want to define the difference between the two of them. Make sure your patient's not actually talking about real dizziness. Also, if someone is lightheaded, don't forget to ask them about any blurred vision or like the peripheries of their vision going black, typical signs of pre-syncope. So if someone has been syncopal, as we said before, you want to make sure they've actually had a loss of consciousness. If someone's had a loss of consciousness, what other questions are you going to ask them about it? Yeah, so what kind of questions are you going to ask to rule out whether it was a fit? Yeah. Anything else?
Anyone witness it?
Yeah.
Very confused afterwards.
Yeah.
Muscle aches afterwards.
Yeah. What might you ask the witness?
Were they jerking?
Yeah,
Yeah.
exactly.
And timing as well. If it's a seizure, then you want to find out how long it is.
Okay. And then lastly, autonomic symptoms of MI. You want to ask about nausea and sweating as well. Okay? So that's your presenting complaint and your associated symptoms.
Okay, so past medical history. In your cardiac history, you really want to, I know in your third year you tended to go straight into, what have you ever suffered from before? Have you been in the hospital before? Have you had any surgeries before? And then your JADE, TAB, MARCH. In your history station in final year, you have to do a focused history. And so we think that what you should really do is really focus on cardiac, because it really affects their prognosis when they've come in again. For example, if they've known to have ischemic heart disease, then it also makes you think about more questions what you need to ask them. If they've had more hospital stays, for example, if they've had a CABG before, or if they've just had PCIs, if they've had stents put in, whether they've had a valve replacement done, if they've got a pacemaker in and they've come in with an arrhythmia, it might be something wrong with their pacemaker. You want to find out whether they've got heart failure, because they might have presented with shortness of breath, and actually it might be an exacerbation of that and it's not being well controlled. So the idea is to try and rule out the cardiac past medical histories, and then go into how many hospital stays you've had, and do you suffer from anything else, really. You want to think about your drugs and allergies as well. So what common drugs are there in cardiac that you want to ask about patients? What are the cardiac drugs? Sorry, say that again. Yeah, aspirin. Beta blockers. ACE inhibitors. ACE inhibitors is really important, especially in your cardiac history. I think in one of our stations we had a patient who had collapsed, and what is one of the differentials for a collapse? Postural drop. So if you know that they're on ACE inhibitors, we could ask them when we started on them, or if somebody's coming with poorly controlled hypertension, you could ask them how often they're taking the medication. So it's really important that you try and figure out what cardiac medications they're on as well, and then you could ask them out other ones. So there's ACE inhibitors, beta blockers, diuretics. You ask about statins, because sometimes in their past medical history they don't tell you that they've got high cholesterol, and then when you look at the drug history they say they're on a statin. And warfarin's really important as well, because if they've had a collapse, then you need to investigate further if they've possibly got bleed anywhere or anything like that. The other thing is really important is in your cardiac history you want to rule out all the risk factors. So as an F1, what you tend to do is you'd cover the risk factors in your past medical history, but for your OSCE it's really important that it's still really systematic. You go through the social history, the family history, and systems review as well. So the key risk factors are, you need to know, I tend to split them into things that you can prevent. So preventable risk factors and non-preventable risk factors. So from that list, what are your preventable risk factors?
Smoking,
Yeah.
alcohol,
Yeah. Cholesterol, yeah. Hypertension, yeah. What else? What are your non-preventable risk factors? Age, yeah. So who's more at risk of having a heart attack, men or women? Yeah. So it's really important that you find out what the risk factors are, and usually, I mean, in your cardiac placements or when you go into MAU, they tend to list those risk factors first, even before their past medical history, because you want to know how at risk these patients are of having a heart attack in the future. So it's really, really important. And don't forget about CVA, and so the risk of having a stroke, or if they've had TIAs in the past, and if they've also had atrial fibrillation, because you want to figure out their CHADS-2 VAS score. So has everybody heard of that score? Yeah, CHADS-2. It's not just CHADS-2 anymore. It's CHADS-2 VASC-2 score.
It's just if they've got vascular disease
Yeah.
and past medical history, it's an added risk.
So it's changed. So make sure you're up to date with.
And that's why you have to ask about the DVT, the PE, and the CVA, because
Yeah.
even though it's not cardiac, it's vascular, and obviously cardio and vascular are linked.
Okay, and then again, in your systems review in third year, you'd usually go through every single system. You don't have time for that in your final OSCE, so you want to really just bring out the salient points, and then if you feel as though you want to rule out if they've got anything else, then you can ask them about it at the end. So we've just really put a list of all the differentials. Sarah's already been through it with you, so I won't go into it in detail again, but like in your history of presenter complaint, you really want to be thinking about all these things. So if somebody's coming with chest pain, you want to think about gorge, you want to think about a PE, if it's musculoskeletal. So usually after your history, you'll do an examination, and quite often, I've taken a full history from a patient thinking it's cardiac chest pain, and then I start examining them, and they've got some sort of costochondritis. So sometimes, the history doesn't tell you everything. You really need to examine them properly as well, and we'll go into that.
So don't forget to ask questions, sorry I didn't mention before, about chest pain. So like, does it hurt more when you take a deep breath in? So pleuritic types of pain. You can even ask them if you press on your own sternum, does it hurt? Have you injured yourself recently? Things like that.
The idea is that you want to concentrate on the presenter complaint and think about all of the cardiac things that you possibly can think of, and then start ruling out all the other differential diagnosis. When somebody comes in with chest pain and it's crushing, you don't want to start suddenly going into asking them about whether they've had indigestion or ulcers and things like that. You're doing that purely to show the examiner that you know that you can think laterally, that it's not GORD and it's not heart failure or musculoskeletal. So that's the idea of doing it that way. So it's really good to have a table in your head when you're doing it. So how would you summarise? So in your OSCE station now, you've finished your full history, and the examiner will now. Quite often they'd either stop you or you don't have the time, so you basically will have to summarise after you've finished. Don't rely on the examiner. I think a lot of us expect the examiner to stop us, and not all of them will do. So try and keep to your time, and then leave at least 30 seconds for yourself to summarise, because that's really important. So how are you going to summarise at the end? Can anybody... What key points do you want to bring out in your summary? Because it can't be too long, obviously.
Demographics of the patient, what they came in with, significant history,
Yeah.
what they're going to do about it.
Yeah, exactly. I think I know in my OSCE, I forgot the patient's name because I was so nervous. So if you don't remember the patient's name, don't go and say, oh, what's your name? Sorry, what's your name again? Because it doesn't look right. So instead, you want to say, this is for example, 64-year-old lady who's presented with central chest pain that's radiating to the arm and jaw, if that's the case. She has a past medical history of 2 myocardial infarction and no surgery. Based upon these features, my first differential would be this, this, and this. Now, you want to rule out important negatives as well. So you want to say she doesn't have any shortness of breath, she's not clammy, she doesn't have any nausea, that sort of thing. So the idea is you're not listing every single thing you've just asked the patient, but it has to be really short and sweet. And the more you practice it, the better you'll be at it. So in all your placements, every patient you see, try and present it to an F1. Or I used to start presenting it to nurses because F1s were too busy. So present it to anybody just so you get better at it. And then the idea is you give them one main differential and then 2 other possibilities. If you can't think of any more, don't start thinking of more. You're running out of time. The examiner will want to ask you questions. And often in your history station, they might ask you to summarise, and then if there's things that you want to go on and do, they might ask you to then explain to the patient. So give yourself that time that you'll need to then explain what you think it is to the patient as well. Okay, so you want to say, other differentials would be, this patient could possibly have a PE. I would suggest a further investigations to rule out my other differentials. So moving on to cardiac examination.
I'll just tell you about an example of a history before we move on. So in our final year exam, our cardiac history station, it was about a 70-year-old gentleman who presented with shortness of breath and dizziness walking up a hill. So does anyone have any ideas what they'd be thinking of first?
So from what we've talked about, what types of things are running in your head already?
Angina. But he didn't have any chest pain, did he?
Sorry?
Sorry?
So this is
COPD,
the kind.
yeah?
Yeah, you could think about
Yeah,
that.
because you've got to think about other causes.
Your heart failure?
Heart failure, yeah. Yeah, aortic
Yeah.
stenosis, bang on, that's what it was. So you needed to ask him about his shortness of breath, get all the details of his exercise tolerance, rule out other causes like COPD for his shortness of breath, so was his chest tight at the time. He also felt dizzy, so we had to rule out causes of dizziness. And actually, he collapsed, so that was the main bit that you had to rule out with the differentials. So the collapse was walking up a hill, so it was on exertion, but you still had to rule out who saw it. Did you bite your tongue? Did you wet yourself? Were you drowsy afterwards? Do you have a history of epilepsy? Did you have weakness on one side before it happened? It's not common, but I guess you could lose consciousness after a stroke. So you had to rule out the other reasons of why he had that loss of consciousness and why he felt short of breath on walking up a hill. The other thing that was thrown in there that I completely ignored was the fact that he drank quite a lot of alcohol because he'd suffered a recent bereavement. His wife had died. So that's another thing, that's another reason you need to ask about their social history, because what I should have asked him was, how much alcohol had you just been drinking before you walked up that hill and collapsed? So just another reason that you do need to ask about all those sections of your history.
I think in your as a final year medical student, even as an F1, when you figured out, okay, what could be the possible causes for this patient coming into hospital, they also want you to, they'll always throw in other things as well. So it won't be a simple, okay, this is a chest pain, so she's got an MI or something. She could have bereavement and be an alcoholic. So as long as you point that out and you know about it, and then you could say, oh, I'd also offer patient help and advice from Alcoholics Anonymous, something like that, or have a psych review as well. Even though there might not be specific marks for that, overall you'll get a really good mark because they know that you're seeing this patient holistically. And the key thing about your history is, if you don't get the diagnosis, don't worry about it. The idea is to go through everything and you'll get all your marks. If your diagnosis is wrong, it's only 1 or 2 marks. It's fine, because when you're explaining about what investigations you're going to do, you're going to say you're going to do these things to rule out certain things. So as long as you could explain why you're doing your investigations, that's fine, and you'll be okay.
Okay, any questions about history so far? Okay, we'll move on to examination.
Okay, sorry, that's me. Okay, so key aspects of the examination. You know them all, so you want to do general inspection first. So you split them up, general inspection, peripheral examination, then you want to look at the JVP. So I move upwards rather than going to eyes and then moving back downwards. So it depends how you guys do it. Then move on to the chest. Chest is split up into inspection, palpation, and auscultation. And then again, unlike your third year examinations, you want to summarise at the end. Okay. And then you're going to be asked by the examiner, what investigations would you like? Key thing in your cardiac examination is, at the end of it, if you have an ECG, which most likely you'll have, which won't necessarily show what the patient has presented with, by the way, so don't worry. If you find aortic stenosis and the ECG shows an MI or something, you're not expected to put 2 and 2 together. They're just testing you to see whether you could identify an MI, so don't worry about that. The idea is, with your investigations, if you don't say, I would do an ECG, they will not show you it. Same way in a respiratory station, if you don't say, I would now do an arterial blood gas, they won't show you the findings of it, so make sure you do it thoroughly. Okay, so general inspection. What types of things are you looking out for in a general inspection? Really simple things.
Things around the bed space.
Yeah, what's around the bed space? So what types of things would you find? Yep, GTN, oxygen, walking aids, yeah. So in your third year, you usually were just sort of reeling off everything you could think of. This is just, you say what you see, basically. And then if there's not a GTN there, then you could say, I said it, I didn't think I saw one, so I said, oh, there's no GTN spray here. There's nothing really else in the around the bedside, but other people's stations were a bit different as well. So I tend to split it. What's around the patient, so GTN spray, oxygen, telemetry. Does everyone know what telemetry is? Yeah, it's a cardiac monitor, so it's a 24-hour tape basically, and it's usually they hide it quite well actually. So women carry it around in these little handbag things that just strapped around their neck, and it's white usually, and you don't often see the leads as well if they're covered. Cigarettes, drip, and then I then split it from what's around the patient and on the patient. So do they look comfortable? Are they sat upright? Do they look unwell? You could possibly get a patient who does have a higher respiratory rate than yourself. Might appear a bit clammy, but they'll be stable. Expose and position the patient is really important. In my cardiac exam, the lady was sitting on the chair and she still had her gown on, and so I was really confused, and it took about a minute to try and get her to sit on the bed, and she was hard of hearing, and it all was a bit of a mess. So make sure that the patient's exposed properly and it's at a 45-degree angle. So peripheral signs, what are you looking for in the hands? Yeah.
So what are they a sign of?
So what are the signs of? Yeah. So everyone always mentions Janeway lesions and Osler's nose, but I've never seen them on a real patient before. So think about common things are common, and leads will always give you common things. They're not going to give you anything that's really random, unless you're really unlucky. So think about signs of infective endocarditis. Yeah, you've got your Osler's nose, you've got your Janeway lesions. But things more common, such as clubbing, you could possibly get a patient with clubbing. Tar stains, that's someone with tar stains. Cap refill, so hold it down, and then so say what you're doing with cap refill, hold it down for a number of seconds, and then release and say, oh, cap refills within 2 seconds. A lot of people don't do it properly, and they get caught out on it. Check for anemia in the palmar creases. Okay, so what's that? Splinter hemorrhages, yeah, so that's other signs of infective endocarditis. Pulse, what are you looking for in the pulse? Yeah, so what I do is I tend to time my pulse and respiratory rate at the same time, so I'll take 30 seconds and do 15 each, and that's the best way of doing it. Everyone always forgets to do respiratory rate, even in a respiratory station, so make sure you don't forget it. I've forgotten to write it on here, so make sure you don't forget it. That's some clubbing. So rate, rhythm and character. You want to know if the patient's in AF or not, basically. And don't say, oh, it's about 72 beats per minute. That patient's pulse has been timed before you got there, so the examiner will know what it is. Don't make it up. And then the key things for checking your pulse is you want to check for radio-radial delay. So check it, say there's no radio-radial delay. I usually say if there was, then I check for radiofrequency as well. When do you check for collapsing pulse, and does anybody know how to check for collapsing pulse? Yeah, you did it right. So you do it in aortic regurg. So I tend to ask my patients, do you have any pain in your arm or your shoulder? Because a lot of them are really old and frail and they've got arthritis. And the last thing you want to do is get them to scream ouch in the middle of your exam. So yeah, basically what you do is put your palm of your hand around the pulse, basically, because you want to feel it at this side of you want to feel the pulse bounding at this part of your palm, basically. You can't feel it as well with your finger pads. Okay, and then you just lift it slowly, and you should be able to feel the pounding pulse of the collapsing of the aortic leakage. And then whether they've got a slow rising pulse or not. So when do you get a slow rising pulse? Yeah, aortic stenosis.
Just with the hands thing, what we're trying to say really about the whole endocarditis and signs in the hands, in your 5th year OSCE, you're not going to have time to say there's no J-Wayne's lesions, there's no ulcers, there's no splinter hemorrhages. So you've got to find a way of grouping all your symptoms together to show that you know what you're looking for. So there's no peripheral stigmata of endocarditis. If they want to ask you about that, they can ask you. But it just takes up too much of your time to keep reeling everything off. So that's what we're trying to say. Group things together in a systematic way to show that you know what you're looking for, and then they'll be able to tell that you know what you're doing.
Okay, in the eyes, what's that? Yeah, phantasma, isn't it? So what's that a sign of? Hypercholesterolemia, yeah. Checking for pale conjunctiva, sign of anemia, yeah. Malar flush? Mitral stenosis. When else can you get malar flush? Sorry? Yeah, SLE. That's a typical butterfly rash, but when else can you get it? And it's quite common. Not really.
It's not called malar flush though. Malar flush is the one that you get from mitral stenosis, or more commonly it's actually from pulmonary hypertension.
So, and you want to check the patient's hydration status. So, look in the eyes, ask the patient to open their mouth, and then you want to just say, okay, the patient's well hydrated and good oral dentition, basically. Because if they've got really bad dentition, what types of things are you thinking of? Yeah, if it's endocarditis. Okay, and then move on down to the neck. So I do carotids first, and you really want to check for volume. Volume and character of the carotid pulse as well, and then move on to JVP. So, does anybody know how to assess for JVP? Because I think everybody really gets confused. I know as a final year I was really confused as well. How are you supposed to measure JVP? Yep. Yep. So from the sternal angle, really you're supposed to measure with a ruler. You never find one on the ward. And then you find where the sternocleidomastoid muscle is, okay, and then you follow it. You follow where the JVP is basically, and you're looking for the 6 characteristics of the JVP. And then from vertically with the ruler from the sternal angle, you're going to follow it and see where it is, and then just see where it is on the ruler. I don't have a ruler, so I can't show you properly. But does that make sense from this diagram? Is that clear to anybody? Is it really unclear? Because I'll try and explain it again. So what you want to do is at a 45-degree angle, find the sternal angle, get a ruler, have it vertical, have a look at the sternocleidomastoid muscle, follow it upwards. Okay, when you see the JVP, then follow where it lies on to your vertical ruler, and that's how big it is.
Does everyone know where the sternal angle is to start off with? Can anyone explain
Everyone's
it?
like,
It's sort of where the second intercostal space is. There's 2 parts to your sternum. There's the top little bit and the longer bottom bit, and it's basically the line between the 2 of them. They join at an angle, and that's the angle of Louis or your sternal angle. So that's where you're measuring from.
so does anybody know your 6 things that you look for generally to distinguish whether this is really a JVP or this patient has a massive carotid?
It's compressible.
Yep. Sorry? Non-pulsatile.
Double waveform.
Double waveform.
Changes with position.
Yeah.
You've been on
You've been on cardiology. What else? You can't say anything now because we've had this teaching session with you. What else?
Change in respiration.
Yeah. So what happens on respiration with the JVP? I don't know who said that, so I can't. Okay.
It goes down with breathing in. On
Goes down
inhalation,
breathing.
it goes down.
Okay. Right. So yeah, positional. So you want the patient to be at a 45-degree angle because the idea is where the JVP lies, where the internal jugular vein lies. The more you stand up, the more it falls further down. So that's why you see a lot of consultants try and position the patients to try and get where the JVP is, and sometimes you need to reposition them. It might not be that everybody's JVP can be seen at a 45-degree angle. So just always remember that. It's a double pulsation, not like your carotid. You can't palpate it like your carotid, there's no pulse. You could occlude it and it will fill. And it varies with respiration, so on deep inspiration it decreases. And then it's now called the abdominojugular reflux, not the hepatojugular reflux, because they don't know the causes of why pressing on your liver causes your JVP to rise. There's not a specific. There's lots of theories, but there's no specific sort of exact reason for it. So is everybody clear on JVP? In your exam, in your OSCE, don't spend lots of time on your JVP with the 6 characteristics. This is just so for you to quickly reel off in your head when you're doing it if you're a bit confused. And lots of patients have a raised JVP because they've got fluid in the lungs. So, really look out for it because it will be a mark.
I think the easiest way probably to tell if it is the JVP or not is if you see something pulsating, just lightly press your finger on it. Lightly though, because if you press deeply, you're going to feel the carotid anyway. So just lightly press on it. If you can feel it pulsating, it's probably the carotid. If not, it's probably the JVP.
Yeah. So chest. So after you've checked the JVP, done the carotids, you move down to the chest. Make sure it's adequately exposed. So I know on teaching third year medical students, there was a patient that was exposed and had her sort of cardigan like this, and the sort of just exam